I showed something called a driver diagram during the presentation, where the secondary drivers are the evidence base, the primary drivers in the middle are the care execution by the physician-led care team, and the outcomes are directly driven by that. So in oncology, there's a number of secondary drivers to the evidence base that are very important that have to do with process and disease management. What we discovered by focusing on the primary driver column, our practices, how we deliver care, was that there are a number of parameters, internal parameters, that patients are blind to and payers are blind to that really drive the desired outcomes. You know, the desired outcomes in oncology are pretty self-evident. The right care, the right specialty care, surgery, medical oncology, radiation oncology, and so on. Palliating symptoms from day one, keeping people healthier to keep them out of the acute care facilities, providing a platform for rational care at the end of life, and having open and honest discussions. So in order to do that, you have to take all the secondary drivers, the good works of the NCCN, the American College of Physicians, the NCQA, incorporate that into our daily work environment, and then measure key things. So a number of key things that are central to driving those outcomes would kind of surprise some people. Or the magnitude of the importance of a few of them would surprise some people. So for example, we know that completion of a care management plan or a progress note in a timely fashion drives a number of those outcomes. It's probably the most important parameter that we follow functionally. Initially we started following 36 different internal performance parameters. Now we're down to about 12. Because the other ones we took and we made them the default mode, so there was less variation. But really there's a handful of very important internal metrics that payers and patients are blind to, but providers need to watch.